From theheart.org radio, in collaboration with Mayo Clinic, you are listening to Mayo Clinic Talks with Dr. Bernard Gersh.
This is Bernard Gersh at the Mayo Clinic, and with me is Dr. Amir Lerman, a colleague, very much of an old friend, and he's in his role as a professor of medicine and director of the chest pain clinic, and is really going to discuss the non-revascularizable patient. Welcome, Amir.
Thank you.
Give me just give me an idea of the scope of the problem. I mean, how many of these patients are out there? Patients who've had bypass surgery, they've had prior PCI, they have recurrent severe life-limiting, not life-limiting, quality of life-limiting angina, and they need new therapies.
That's a very important question, because I think the incidence of the disease is a moving target, and I will explain myself. I think it depends, highly depends on the recent development in technology. So if you talk about the definition of disease or the prevalence of disease 10 years ago, people believed that it was about 20% of the patient undergoing coronary angiography. However, currently, when you have new technology for revascularization, the incidence may be declined to about 15% of the patient coming to the cath lab with angina. If you're talking about number, the estimate number is very difficult to estimate, but it's in some data in ours and other centers, it's about 100 to 200,000 patients a year in the United States.
So it's very much, it's a big problem. So about 15% of people that come to our cath lab with symptomatic angina are non-revascularizable. And what proportion do you think of those are people that have had prior procedures? Must be the vast majority.
The vast majority, yes. So I think that what we define as a non-revascularized patient are patients that majority of them has some kind of intervention procedure in the past, or bypass surgery, or PCI,
or
both. In a lot of cases, both.
So Amir, when we talk about what we can do for these people, obviously secondary prevention, risk factor modification, control, all those variables. But what do you define as a failure of medical therapy?
So I think we need to define what's the challenge of the treatment of this patient and what are we trying to achieve. It was believed when this issue was initially targeted that these patients are carrying a high rate of event and mortality. And that's
not so.
No. It's actually, and that was one of the initial treatment was under the assumption that these patients have a high mortality.
So these are people who are leading miserable lives, but they don't die.
So data from other centers and our indicate that their rate of mortality currently is between 4 or 5% per year. Now, not only that, half of them don't die from cardiovascular disease. So
right.
You're talking about mortality rate about 2.5% from cardiovascular disease. It's very difficult to design a therapy which is less invasive, which have no...
Well, why do you think the cardiac mortality is low in this group of people with bad disease?
Because I think they are survivors. I think they went through acute MI, the non-ST elevation MI, ST elevation MI, was able to survive, and then they live collaterals, and they live with chronic angina and ischemia, but they are able to live without having a significant event.
So the challenge is to improve the quality of their lives. And let's go back again to the definition of optimal medical therapy in 2012.
So I think that in my definition and other people's definition, the definition for optimal medical therapy in this patient is to be able to improve their quality of life without creating adverse event.
Right, and so what would you define as the optimal pharmacologic regimen?
So we need to, first of all, the measurement should be their angina attacks, the number of nitroglycerin they use. Currently, the medications that are used are nitroglycerin, nitrate, ACE inhibition, beta blockers. In some cases, calcium channel blocker, but in most of the cases now, two medications are being added. One of them is ranolazine Renexa, which is probably the only anti-anginal drug that came on the market in the last 20 years since nitrate. And there are some studies that adding L-arginine to this patient from the...
for endothelial function.
For endothelial function microcirculation.
I want to just stop you for a moment. and make one point. I am struck in my own practice how many people on nitroglycerin with angina have never been told to use it prophylactically.
Yeah. You're right, and we indicate to our patient to do a preemptive, and to, for instance, if before exercise, before even, you know, some of them have angina attack in response to mental stress, we advise them to do that. The issue with nitrate is that nitroglycerin do not work on the microcirculation. So if we believe that at least part of their angina is resulted from the microcirculation, then in this patient nitroglycerin will not work, and ranolazine will probably do a better job.
So before we say medical therapy has failed, and then I want you to discuss some of the procedures, we would insist on a failure of a beta blocker, prophylactic nitroglycerin, the addition of a calcium channel blocker if tolerated, and the addition of ranolazine.
Yes.
Okay. ACE inhibitors may play a role, but may not. Depends whether hypertensive, endothelial dysfunction, and so on. Yeah. So, briefly, because there are a lot of interesting procedures that are still ongoing, give us quickly the history of the procedures that have failed, like translaser, myocardial revascularization.
So the initial procedures were actually designed from the assumption to increase the density of the microcirculation and induce angiogenesis. So there are two main procedures that we use. One of them is to induce angiogenesis under a physical injury, such as a TMR and PMR.
TMR is translaser, myocardial revascularization, PMR is percutaneous. Yeah.
So this procedure were invasive in nature, and that carry with them adverse event and risk. So, it's not that they were not able to reduce the angina, but the perioperative mortality and risk was about 4 or 5%.
But I thought also that the only double-blind trial showed was probably a placebo effect.
There is placebo effect too, and the proof if they really induce angiogenesis is still not completely clear. So, but the problem with these procedures is that they carry a lot of perioperative mortality because of the invasive nature.
But which was the trial? The one randomized trial really showed no difference in symptoms.
This was the percutaneous one.
Yeah, percutaneous myocardial revascularization.
Now the second one was again from the same principle that you want to induce angiogenesis to increase perfusion. Was many studies that use delivery of cells like VEGF and PGDF. To induce angiogenesis.
Cells or proteins?
Cells and proteins. And all these studies did not show significant improvement in exercise capacity that were...
So basically gene therapy for angiogenesis hasn't worked. There is, and we discussed this in one of the other interviews, there is an interesting cell therapy trial from Doug Lasorda with CD34 progenitor cells, which does appear to reduce
the difference between these cells is that you may be trying to do different things. We're not sure if it's inducing angiogenesis. And also the future studies of this cell delivery may be based on special delivery to area that we think are at risk.
So, Amir, what have we got right now in the armamentarium available to us in the chest pain clinic? So the patient has failed. They're not going to go into a stem cell trial. We've got EECP. And transcutaneous stimulation.
And we have new shockwave therapy.
Tell us quickly, briefly, what you think of the ECP. Do you think it's placebo? Do you think it's real?
No, I think the ECP is real. I think it's real. I think we see a good response to the ECP. The mechanism is still under a lot of speculation. I believe that's at least part of the mechanism that we break the cycle and do passive exercise on these patients, then they improve their capacity. So I think that the ECP is real.
Do you think that the shear stresses, alter shear stresses, may change endothelial function?
Shear stress, we show previously that in other groups show that improve endothelial function. It's very difficult to discriminate between the improvement in parameters and improvement in exercise capacity.
Yeah, I have to say, though, in some patients, the magnitude of the benefit is so great that I just can't believe it's all placebo. There's something going on that we don't understand.
No, I think the ECP is real. There are some limitation about you can't use it in all the patient, and the limitation of how many treatment you have to have. You have to have 35 sessions, and it's not so convenient to the patient. But it's real. And
so tell us about transcutaneous stimulation. The first step would be EECP.
Yeah.
Then if the patient fails that,
so we evaluate the patient for the spinal cord stimulator that is being used for many years for other pain relief mainly diabetic neuropathy or spinal stenosis. And currently we work together with the pain clinic to see if they respond to the stimulation. So we don't put it in with the anesthesia until we have proven that this is actually works for this specific patient. I do think it works specifically for patients that have pain threshold and the issues, and not necessarily all of them are ischemic derived. But we see some patients that were able to see good response in the spinal cord stimulator. There was a study funded by Medtronic that the results are going to be out soon, randomized study by the spinal cord stimulator. The other new technology that is coming to light is what we call a shock wave therapy, which is actually using the same ultrasound wave that is used for lithotripsy for the kidney in like 10% of the energy to deliver to area of at risk under echo guidance.
Transendocardially?
No, from the outside chest.
So you look at areas that are viable
and ischemic.
And
you deliver a series of, by protocol, a short shock wave therapy. It's very popular in Asia. There are some good data from Europe. And
so what are you achieving other than banging the heart on the head, so to speak?
Actually, there's data. There are two things that you can achieve. One of them is there is a data about angiogenesis from animal models. And second, and this is an old data that actually was initiated not from the heart but from the joint therapy, that it may enhance recruitment of stem cell into the area of ischemia.
Well,
and Andreas Zaire in Germany was presenting some of this data that he's using.
There's some interesting data. You're right. It's from Andreas Zaire in Frankfurt, where they're using shockwave therapy to modify the environment for subsequent stem cell implantation.
So the data is encouraging. There is some preliminary data from a safety data that we at Mayo were the central site for that. And the initial data that was not a randomized study show it's safe, and it's resulted in increased exercise capacity. But we still need to do a good randomized study before it become a more standard therapy.
So Amir, just in closing, I want to make a comment and then also ask you just to speculate a little bit. One thing I have noticed in working in the chest pain clinic, which is not easy. These are patients who've had many, many procedures, and it's often very difficult to decide whether one is dealing with angina. And I really do feel that there's a lot of functional overlay. They're very challenging patients that one has to speak with and deal with very frankly. But what I wanted you to speculate is, we're sitting here in 5 years' time having the same interview. What else will be up in front of us?
Well, I think that the challenging for a new device and a new therapy is actually reside not by the technology, but by the fact that you currently new technology and medication are challenged by the FDA to see that they improve quality of life rather than event. So if you design a new therapy and you want to introduce into the market, you need to show reduction in event, which if you have a population that have such a low event rate, it's very difficult.
So what about in less regulated environments, perhaps?
So I think that we will see more devices like the shock wave therapy, maybe a modified ECP that will not require a long-term therapy for that. And we are optimistic about the cells. We're optimistic that if we are able to deliver cells to the specific area of ischemia and variable area, then maybe we can increase that.
Last thing, do you think that there's an avenue in terms of understanding and perhaps synthesizing the signaling pathways that underlie ischemic preconditioning and then precondition these hearts?
Yeah, I think it's also an area that is should be explored. I think there is controversial data about the precondition, whether it's going to be a remote precondition or direct precondition, and I think this is something that could be explored. It's also possible that the ECP by itself is sort of a kind of remote precondition, that you actually do that by inflation and deflation of the.
So the message for our audience is very clear. There are a large number of patients. They have failed revascularization. We need to pay attention to prevention. Obviously, the use of prophylactic nitroglycerin. We have a new anti-anginal in ranolazine to add to our current armamentarium, and then all is not lost. I mean, we do have these three other options: ECP, maybe shockwave, transcutaneous stimulation, and we'll see where the cell repair therapy how it plays out over the next few years.
Yep.
Thanks very much, Amir.
Thank you very much.
Great to have you.
Thanks.
You've been listening to Mayo Talks with Dr. Bernard Gersh. Visit theheart.org to find out more.